Hi everyone, welcome back to the channel. My name is Drew. I'm an accredited exercise physiologist and also a registered Chinese medicine practitioner. And I've been practicing clinically in kind of the exercise rehabilitation, Chinese medicine, musculoskeletal health space for 25 years or so. And what I like to do is integrate both modern understanding of exercise sports science and rehabilitation techniques and traditional Chinese medicine. Today, we're going to be looking at the shoulder with a kind of overview of understanding shoulder mechanics. And then this is going to set up a series of videos where we're going to explore some potential shouldery stuff that we can come across. So we'll be looking at muscle actions, joint actions, acupuncture meridians, key acupuncture points, and then exercises, both Western medicine exercises and also traditional Chinese medicine approaches, and just to kind of more share and explore different methodologies and different approaches on how we can rehab. So the first thing is always got to understand the body and what's going on. And for today, we're going to be looking at the shoulder movement, and we're using the Muscle in Motion app, the yoga app. We're in the kinesiology skeletal section. We're in the torso section, and you'll find the shoulder section here, so you can jump on in and follow along at your own pace. So we have this really good diagram here of the shoulder. So let's let it run through. So this is shoulder abduction, so when the arm comes out to the side. And essentially what we want is the shoulder to come out to shoulder abduction. Yeah, so this is essentially where the arm is almost parallel to the ground. So this is usually we call it around about 90 degrees shoulder abduction. So think abduction, abduct, so abduct to take away. So we're taking away from the midline. And then notice the shoulder blade change position as you go above the line of your armpit, essentially. So here you'll see the shoulder blade itself has to move with it. And then you can see the orientation of the scapula, and this part here of the scapula is called the glenoid fossa. So that's where the round part of the humerus kind of sits into the glenoid fossa. And you can see that like half of the actual humerus is out of that socket. That's not dislocated, that's just a normal position. And you can see here that the bone is essentially connecting or contacting to the clavicle here, or the acromion process there. So there's no space there. And then as we come down, we'll take it all the way up to there. So this here would be full shoulder range of movement. So we go back to the start again, come back to the start. Now, what's the angle change here? So this angle here, okay, watch this angle change. So right now, it's orientating in this direction here. So basically perpendicular to the ground. All right. Or if you're doing a compass, that would be like a westerly kind of direction, or the arm is straight out like so. Okay. Now, as you come up into shoulder abduction, when you start getting towards that 9-degree shoulder abduction or level with the floor, parallel to the floor, this angle is going to start to change. And that means the whole shoulder blade, the whole scapula is going to start to change orientation. Now, if this shoulder blade movement is not restored, then you are not going to get a healthy shoulder at all. This is not going to work. Because what will happen if you're trying to get your arm above this angle and the shoulder blade doesn't move with it, then you're just going to get jammed up here and you're going to create a lot of impingement in the shoulder, and that's going to be really yuck. So now keep following this angle here. Keep following it, keep following it. And when we get to the end, full range of movement, essentially now that glenoid fossa is facing almost straight up. And that enables you to get your shoulder above your head. Okay, that's full range of movement. So in a shoulder rehab program, we are trying to restore this movement. Now, it always depends on the structures that are involved, and if you've had surgery, what the surgical procedure is, there's always a trade-off between a range of movement and stability with shoulders. So if you've had shoulder surgery, and they generally tend to tighten the shoulder up with the procedures, because if you've had a shoulder surgery, it means that your stability has been very compromised, and so they need to typically position the shoulder so that it's tighter, so it's more stable, so you can use it. The trade-off that sacrifices that is range of movement and mobility, so you get a stiffer, tight, restricted shoulder, but it's stable, so you can use it. Okay, so that's the first thing to appreciate. There are 17 muscles across this joint here, the shoulder joint. It's a very busy joint, lots of things going on. And to understand the shoulder takes a long time clinically to kind of like wrap your head around how it all works together. Because the shoulder blade's involved, we're also then working across all the muscles that affect the shoulder blade. And then because the shoulder blade sits on top of the rib cage, we're going to affect everything that affects the position of the ribs, affects the shoulder blade, which then affects the position of the glenohumeral joint. So there's 3 key areas you need to really consider when you're doing a shoulder rehab program. There's the shoulder joint, so all the muscles across the shoulder joint. So that's the things like your rotator cuff muscles, your biceps, your triceps, your pec, your lats, your deltoids. Okay, so very busy intersection of muscles. Then all the muscles that move and affect the scapula, so things like your upper trapezius, your lower trapezius, your middle trapezius, your rhomboids, your scalenes, the serratus anterior, all really, really essential muscles. They're what we call the scapular stabilizers. And then because the shoulder blade sits on the rib cage, anytime you breathe in or out, the change of the position, the ribs change, which means that the shoulder blade will change position. So then we need to address the thoracic mechanics. So that's your T-spine. And the way you address your T-spine is to teach people how to breathe correctly, so the ribs are moving correctly. So there's really 3 levels to doing a proper shoulder rehab program, in my opinion. So you need to address the shoulder joint, you need to address the scapula, and you need to address the T-spine or the thoracic spine. So we're going to explore some of this in more detail, and then we'll start to dig down into different structures. So let's look at the next slide here. So this is shoulder abduction, and now we're going to introduce the muscles. So we have, let's just come back and start. It's moving quite quick. Pause. So the primary muscle in shoulder abduction is the deltoid. And so you can see here the deltoid's in the red. And there are 3 sections of the deltoid muscle. There's the anterior fibers, the medial fibers, and the posterior fibers. And so basically, you think you're going to reach your arm to the front, you're going to use the anterior fibers. If you're going to reach your arm out to the side, you're going to use the medial fibers. If you're going to reach your arm behind, you're going to use the posterior fibers. So a good deltoid program has anterior, lateral, and extension work in the shoulder. Okay. So at some point, you need to address that in your rehab program. We also have this purple muscle here, which will be the supraspinatus. So the supraspinatus and the deltoids are synergistic, as in like they help each other out to execute the movement. So if we progress a little bit, let's come back to start. So as we're coming up here, this is shoulder abduction. Now notice as well the shoulder blade moving as you do that. Arrows are pointing in the direction of the line of pull. So the supraspinatus is pulling this way and the deltoids are pulling up that way. And so you get that synergistic pull. Get to about there. And now you're going to see here, and this is full shoulder abduction to this position here. So it's not the full over the head yet. So that's a really, really important synergy we need to work together. So to restoring your shoulder abduction, so coming up to the shoulder height. Okay. In anatomical terms, the agonist is the term that we have for the primary muscle doing the movement. So it's usually the bigger muscle that usually has a more fast twitch fibers in the muscle. So typically the bigger muscles are designed to be on generate a lot of strength. Small muscles are generally more endurance-based muscles. So your supraspinatus will be more kind of slow twitch muscles, whereas your shoulder will be more fast twitch typically. Good, so we get a nice representation here. Let's keep going through. And then your synergist muscle is the muscle that helps. Now, a big problem in a lot of shoulder injuries is it's very rare for you actually to injure or damage the deltoid muscle. It can happen, but it's pretty rare. What often happens is the rotator cuff muscles are the ones that are most commonly injured. And in this case, here the supraspinatus would be the one that's injured, and it's going to attach just on top of the shoulder, on top of the humerus here. And even though it's a small muscle, when it gets injured, it will typically inhibit, as in neurologically communicate to the spine, to the brain, saying, we've got an injury. If you keep contracting that muscle, you're going to be mechanically pulling on the structures in the tissue. And so you're potentially going to re-injure that tissue. So it neurologically inhibits the muscle contracting. So basically it's like an off switch, if you will. And so then that basically stops you from using that muscle. And at the same time, because these two are agonist and synergist, they often have very interrelated, interconnected muscle activation. And so then the deltoid won't work because these two work together. If you shut down one, the other one gets shut down as well. So what we need to do is then rehab both of them. Even though the deltoid's not injured, it will get weak, it'll get atrophied really fast. So we need to rehab them both. So you'll see this happening a lot in different injuries where you get agonist synergist muscles. They both often get really weak, just as the nature of the injury. So the deltoid muscle does not become fully active in abduction until the arm has moved through approximately 15 degrees of abduction, which is driven by the activation of spinatus. So this first 10 to 15 degrees here is what this is referring to. So it's the initiation of the movement is typically more supraspinatus. Then the deltoid takes over up to around your armpit level. And then to get your arm overhead, it's a combination now of trapezius and lower traps and rotation of the actual shoulder blade to clear the space to orientate that inferior glenoid superiorly, so you can then get that arm overhead. And so that's where the shoulder blade muscles come into it, and the spine mechanics as well. So here we can see shoulder abduction. And this is a great example of all these other muscles starting to integrate to orientate the shoulder blade correctly. Let's just let it run through. Start. Okay, yeah. So here we have the upper trapezius muscle. Here we have the supraspinatus muscle. Here we have the lower fibers of the traps. And here we have the serratus anterior. So these are really key shoulder blade muscles. And then also these ones here, which are kind of grayed out, middle trapezius, and below that will be the rhomboids through here. So what this slide is demonstrating is this upward rotation of the shoulder to that point there. Now this is only to abduction. To even get the arm above the head, this rotation of the scapula is even more pronounced. So this inferior angle is going to go out this way more, and this muscle is going to keep pulling down here. So one of the really difficult things to kind of wrap your head around is when you're trying to get your arm overhead, you've got to pull your shoulder blades down. So as you're coming up, the shoulder blades roll back and down the body. You don't go into a shrug. If you go into a shrug, you don't get the elevation of this upward rotation of the scapula, and things just get jammed up. It doesn't work. So at some point, you have to address these shoulder blade muscles to get the right pivoting, the right rotation, the kind of scooping up of the shoulder blade. All right. So here we have, slow down, from this posterior view. So we come back a little bit. So this is full shoulder abduction. So essentially your arm by your ear. So imagine doing backstroke. So you're going to reach up. So the angle there is pretty much almost vertical to superior, and that inferior angle of the scapula is really kind of spun outwards, if you will. So from the front, yeah, so that's at 90 degrees flexion. If you keep going, then you have to get up to here. So this is what we need to be able to restore. If you get the right enough rotation, you still have a bit of space between here. So the big problem is we get impingement syndromes where you have this groove here. This is a groove where you have the biceps long head tendon coming through, and then you'll have the supraspinatus tendon sitting up in here. So as you're coming up above the head, they can get compressed or impinged against the humerus. And so you can get inflamed tendons, tendinosis conditions, and that often comes with kind of subacromial bursitis and things like that. So that can be quite yuck. So here we have the deltoid muscle on. So it's the deltoid pretty much there. It's maximally contracted. So it's not so much the deltoid doing any work above this position. Now it's just orientating around, getting this shoulder blade to orientate around. Here we have ligaments. So we've got the anterior glenohumeral ligament, the superior ligament, joint capsule, and we've got a couple of ligaments here. So we can kind of go by the bones. So this is a coracoid process. This is the acromion. So that's the coracoacromion ligament. And this is the clavicle here. So that's the coracoclavicular ligament anterior, coracoclavicular ligament posterior there. So we've got some really strong ligaments. And then this ligament here is the AC joint. So that's the acromioclavicular ligaments, the AC joint. So really strong ligaments around the shoulder. When you have an unstable shoulder or a dislocating shoulder, it's often these ligaments which have been overstretched or potentially torn. And then because the role of the ligaments and the joint capsule is to keep the shoulder bone in the position as the muscles pull and move the limb. So if they're stretched out, then the shoulder can move more around more in the joint, and then it can kind of get in positions where it gets jammed pretty easily. So when I was talking about when they do surgery, sometimes they'll overcompensate with that, then kind of tighten everything up so everything's more stable, so things aren't getting dislocated and jammed up and compressed. So it's going to be the trade-off with that. So full shoulder abduction. Okay, that's what we call scapulohumeral rhythm. So when you get past this kind of 90 degrees position here, then the scapula is going to rotate in a certain ratio to follow the arm. So from that 120 degrees, so that's essentially when the arm is going to be connecting with the acromion process. And people have got different shoulder joint anatomy and shape. So some people have bigger spaces there, so they've got a bit more natural range of movement. And some people have slightly different angles in those shoulders, so they might have more restricted ones. And it's usually the people with the restricted angle, which they tend to get more jammed up. It's just kind of an anatomical component to it. So we have 45 degrees external rotation at the glenohumeral joint. So if you look there, this rotation. So as you're lifting your arm up, there's a natural rotation that happens in the joint. Okay. When you have rotator cuff injuries, often that natural rotation is compromised. So as you're getting up, the actual humerus isn't rotating properly, so it gets jammed up again. And then we have 25 degrees of SC joint elevation. So that's the sternoclavicular joint. So where your collarbone meets in the middle here, that's the joint there, really strong. That's the only joint in the body where the arm actually physically connects to the spine. So there's some movement that happens in that joint as well. So when you breathe in, if you put your hand on your collarbone and take a big breath in, you'll feel that clavicle lift up. That's normal, okay, because you're going to be breathing into the top lobes of the lungs, which are sitting underneath your traps. So as those lobes of the lung expand, there's a natural elevation of the shoulder, so a natural elevation of the clavicle. So that is a normal movement. When you exhale, that should all release and settle down again. Okay, so just something to be mindful of there. So you can see that changing angle there. There to there. Okay. Something to be aware of. And so we get 35 degrees of the acromioclavicular joint upward rotation to there. So that's a big change. The 25 plus 35 equals 60 degrees scapulothoracic joint rotation. So you get an extra 60 degrees of rotation from the scapular-thoracic joint. So just from moving your shoulder blade. Okay, so that extra 60 degrees from here. So if this is 120 degrees here, okay, if we go back a little bit, this is 120 degrees. So when you get your arm up to the side, there, then to get your arm by your ear, there's 180 degrees. So then if you go 120 plus 60 degrees from the scapulothoracic, that gives you 180 degrees of movement. So you need to restore that 65 degrees of movement from the scapulothoracic. Excuse me. Okay, so got a bit of a cough going on. Now here we're going to be looking at the rotation of the clavicle. So this is the sternum, this is the mandible, this is the clavicle, this is the superior spine of the scapula. This is the scapular body here, and this is the fossa of the scapula. So this is where the supranuis is going to sit into, and it's a great diagram here. So this is this arm resting by your side, and then boom, look at that. Let me just slow it right down. So from here, and look at spin underneath. That's what we need to restore. Okay, that's the goal. That's what we're trying to get to. Okay. If you don't restore this movement here, you will not get proper shoulder movement again. And the issue here is if you can't restore that full range, then if you're trying to reach overhead, then the body has to then do more spinal extensions, more of a back bend to kind of passively change the orientation of the shoulder to reach up. So you use your lower back more. So sometimes you'll see people with shoulder problems develop lower back problems because they're compensating in their lumbar spine to make up for the lost range of movement in the shoulder. So we want this scapulohumeral rhythm to be restored. It's usually about a 2-to-1 ratio. There we go. So for every 3 degrees of abduction, 2 degrees of glenohumeral joint, we get 1 degree occurs by scapular upward rotation. So what that means is for every 2 degrees you move your arm upward, okay, the shoulder blade spins upwardly 1 degree. So it's a 2-to-1 ratio roughly. So we really want to try to restore this movement as much as we can. Now, my big concern or big gripe or the thing I see the most happen is being an exercise physiologist. What I see all the time is people are prescribed these little kind of banded internal and external rotation exercises to try to rehab this shoulder. I mean, one of the rotator cuff muscle might be injured. Let's say it's a supraspinatus. Supraspinatus doesn't do internal external rotation, so I don't even know why you're giving that exercise, but it seems to be really common. it's a misunderstanding of the anatomy of the shoulder. But maybe let's say if it was the infraspinatus or the subscapularis, which are rotators of the shoulder, so they get these little band movements. The problem is that those movements are designed to work with this shoulder blade movement, as we just kind of described. So if you don't actually integrate the shoulder blade movement with the rotation, then essentially what you're doing is you're just jamming shoulder up, you're putting the muscle in a poor position to contract. And so what will happen is other muscles will take over and execute the movement, which is the other big problem with those small movements. If you're looking at, for example, subscapularis, which is a internal rotator, it rotates the humerus inward. So it's like a roll of the shoulder in movement. That does on its own do that, but we also have the pec major, the latissimus dorsi, which are also internal rotators. So they will just do that because of huge muscles. And so you can kind of execute that movement, but not really be using that subscapularis. So the trick is to integrate everything together, and it really does take quite a nuanced approach to it to understand the exercise prescription. So what we're going to be doing in the next couple of videos is looking at some exercises we can use. And then we'll also be looking at a kind of Chinese medicine approach and using things like Qigong to get the movement mechanics correct. And then we'll also start discussing meridians and energy and how that works in the shoulder as well. So until then, I hope you're having a great day. If you have any questions, please feel free to like, comment, and share. Always really love getting your comments, and I look forward to seeing you in the next one. All right, ciao.